to my channel. Today I'm going to discuss a very important topic, that is screening, and this is included in Family Medicine chapter of Toronto Notes 2025 edition. And so let's take a start. And if you want to follow along, this is page number 4 of the Family Medicine chapter of Toronto Notes. Okay. So the first screening we have to read about is the breast cancer screening. Okay, so always remember, for a woman between the age 50 to 74 years, it is recommended in Canada screening, that is a part of secondary prevention, with mammography. Okay, screening is always done with mammography, and it is done every 2 to 3 years. Okay. Now, the next thing is that decision to undergo screening is conditional on the relative value that a woman places on possible benefits and harms from screening. Okay, so the simple thing is, for all the women age 50 to 74 years, mammography is recommended every 2 to 3 years, and the decision is based upon the risks versus benefits. Okay, of course, definitely, if the benefits are more and the risks and harms are less, then definitely screening is recommended. Now, for women age 40 to 49, okay, age if it is between 40 to 49, recommend not screening with mammography. Okay, no screening is needed with mammography. The decision to undergo screening is conditional on the relative value that a woman places on possible benefits and harms from screening. Okay, now recommend not performing clinical breast examination or self examination to screen for breast cancer. This is very important line, because I saw an MCQ in one of the Q banks regarding this, that whether we do the clinical breast examination as a part of screening tool. No. So, in Canada, it is not recommended to perform clinical breast examination to screen for breast cancer. It is conditional recommend. It has no evidence, no proven evidence is there. Now, next thing, recommend not advising women to practice breast self-examination to screen for breast cancer. Okay, neither it has any evidence for screening, neither if women practice breast self examination periodically, it has no advantage and it is not used for screening purpose. Okay, now the next thing, recommend not using MRI, tomosynthesis, or ultrasound to screen for breast cancer in women not at increased risk. Okay, again, as we read already, that mammography is a main tool that is basically used for screening. So other tools like MRI of the breast, ultrasound, to screen for breast cancer, that is not recommended. Okay, especially those who are not at increased risk. As per Ontario Breast Screening Program, people aged 30 to 60 who meet high risk eligibility criteria should get screened annually with both mammography and breast MRI. The first thing, before we read that between age 50 to 74 recommended for all the women of all the basically all the women, whether they have the risk factors or not. But here they say that people who are between the age of 30 to 60 and they are at high risk, who meet high risk eligibility criteria, means those females who are at high risk of getting breast cancer, they should get screened annually with both mammography and breast MRI. It is not even 2 to 3 years, it's annual screening with a mammography and MRI. And these are high risk females, means maybe they have a family history of breast cancer, they have a family history of male breast cancer, maybe they have a personal history of cancer, or the things like that. These are basically definitely at high risk of breast cancer. Okay. Okay, next thing, lung cancer screening guidelines. Now, what is lung cancer screening guidelines? For adults age 55 to 74 with more than or equal to 30 pack year smoking history, who currently smoke or quit less than 15 years ago. So basically, for adults age 55 to 74 with 30 pack year smoking history, and either they are smoking currently as well, or they quit smoking less than or equal to 15 years ago. Recommend annual screening with LDCT, low density CT scan. Okay, up to 3 consecutive times. Okay, so CT scan is recommended up to 3 times. Screening should only be carried out in healthcare setting. Expertise in early diagnosis and treatment of lung cancer. Okay, so it should only be done in a specific healthcare setting where this early diagnosis and treatment of lung cancer can be done. Okay, so annual screening is recommended with a low dose CT scan. Now, for all other adults, regardless of age, smoking history, or other risk factors, recommend not screening for lung cancer with okay, so only this age group screening is recommended with low dose CT scan. Okay, up to 3 consecutive times. Okay, and for all of the individuals with a history of smoking or not, or not screening is not recommended for lung cancer. So OH group matters a lot, 55 to 74. Okay. Recommended chest X-ray not be used to screen for lung cancer with or without sputum cytology. So chest X-ray is not used as a screening tool for lung cancer. Okay. It doesn't matter if we do sputum cytology along with chest X-ray, yes or no, doesn't matter, but it is not recommended as a tool for screening. Now, as per a screening program in Ontario, screening is recommended for adults between age 55 to 74 who have smoked cigarettes every day for at least 20 years. Okay. So any person age 55 to 74, that is 30 pack year smoking history. Okay. And he's continuously smoking every day for at least 20 years, then a screening should be done for that person with the low dose CT scan. Now, the colorectal cancer screening guidelines. Now, what happens that recommend screening adults age 60 to 74. I will revise the ages one more time. For lung cancer, the age group is 55 to 74. For breast cancer, the age group is 50 to 74. Breast cancer 50 to 74, lung cancer 55 to 74, colorectal cancer 60 to 74. Okay, so screening is recommended for individuals between age 60 to 74 for colorectal cancer with fetal occult blood test. Okay, either fetal occult blood test or fetal immunochemical test, so both are okay, every 2 year, or it should be done every 2 year. Fit test should be done every 2 year. Fetal occult blood test or fit test should be done every 2 year. Or can you see a big or? Yeah, okay. Or flexible sigmoidoscopy every 10 year. Or invasive procedure is there like flexible sigmoidoscopy. It should be done every 10 years. Strong recommendation and moderate index. Okay, either we have to do the fecal occult blood test or sigmoidal, basically what sigmoidoscopy, that is and a type of endoscopy to see or visualize the sigmoid colon. So sigmoidoscopy every 10 years, flexible sigmoidoscopy every 10 years. Now, recommend screening adults age 50 to 59 for colorectal cancer with fetal occult blood test every 2 year, or flexible sigmoidoscopy every 10 year. So now they are making a bit less age, like 50 to 59. Again, the same thing, screening with fetal blood test or flexible sigmoidoscopy every 10 year. And these are weak recommendation, and but moderate quality evidence. Okay, now recommend not screening adults more than 75 for colorectal cancer. We don't have to screen those whose age is already more than equal to 75 for colorectal cancer. Recommend not using colonoscopy as a screening test for colorectal cancer. Colonoscopy can be used as a screening test for colorectal cancer, but not colonoscopy. Okay, now this is a table that we need to read average risk and not at average risk. So, first thing first. So, what is the average risk for those? We start from the age 50 to 74. Here, like they said, 50 to 59, then 60 to 70. Just make it simple, 50 to 74. Okay, these people need to be screened. Asymptomatic, age is 50 to 74. Okay, asymptomatic person, no first relative diagnosed with colorectal cancer, no personal history of colorectal cancer, Crohn's disease, colon, rectal colitis, no polyps needing surveillance, and uh, coverage is also there. Okay, so basically there's nothing else, just the age group 50 to 74, no symptom, no family history, no first degree relative with colorectal cancer, no personal history, or no colorectal polyps needing surveillance. Okay, now due to screening a fecal immunochemical test we are going to do, maybe normal, maybe abnormal. So fetal immunochemical test, when you are going to do fit test or fetal occult blood test, need to be done. If it's normal, if the fetal occult blood test or fetal immunochemical test came back normal, so we have to repeat this every 2 years. If it's normal, we have to repeat every 2 years. If it's abnormal, what we are going to do? We are going to opt for colonoscopy. Okay, if the fetal occult blood test came back abnormal, so we have to do colonoscopy, and within 8 weeks, means 2 months, we have to do within 8 weeks we have to of abnormal fit test, we have to do colonoscopy. If the colonoscopy appears normal, repeat with fit in 10 years. Okay, if it came back normal, we have to repeat with fit, that is fetal immunochemical test in 10 years. Okay, came back normal, we have to repeat with the fit in 10 years. And if it came back abnormal, treatment or surveillance as per recommendations. Okay, if it came back normal, we have to repeat in 10 years. But if abnormal, then we have to do the treatment as per the recommendations. Now now the other thing we need to know is, what is that? Not touch average. Is your patient at increased risk, one or more first degree relative? So of course, if the family history of colorectal cancer is increased risk, now the colonoscopy start at age 50 or 10 years earlier than the age relative was diagnosed. Take a complete history of cancers in the family. If hereditary cancer syndrome is suspected, refer to genetic assessment as well. Okay, if we are suspecting cancer syndrome, we have to refer for genetic assessment as well. Does your patient have symptoms? Okay, we have to refer for genetic assessment. Okay, now the second question we are going to ask is, does your patient have symptoms, for example, rectal bleeding or anemia? Okay, rectal bleeding or anemia are the symptoms for colorectal cancer, maybe. So refer to specialist for evaluation. Okay, do not use fit chemical test for symptomatic patients. Fit is not used for symptomatic patients. Do not do the fit test for symptomatic patients. Okay. Now, test not recommended for colorectal cancer screening. What tests are not recommended? We are not going to do these tests for colorectal cancer screening. For patients at average risk, if there's just an average risk, we do colonoscopy. For all the patients, metabolic test, DNA. Okay, if the patients are at average risk, we have to do colonos tests which are not recommended for colorectal cancer screening. If it's average risk, colonoscopy in all the patients, blood test, urine test, DNA test, CT scan, capsule colonoscopy, double colonoscopy, or fecal gut blood test. Okay, if there's an average risk, definitely we are not going to perform all these tests. Okay, if it's a high risk, we are going to perform screening with fit test and colonoscopy. If there is basically not no risk, but if it increases, definitely we have to take the history, and we have to do colonoscopy. That's not recommended when there is no increased risk. And then these are the blood tests, the DNA tests, and okay, these are not recommended. This says that's not recommended for colorectal cancer screening. Okay, recommendations are they say the flexible sigmoidoscopy every 10 years. That is also an acceptable screening test. Okay, recommendation of post polypectomy surveillance. This website we can see no flexible sigmoidoscopy colonoscopy in the past 10 years, no fit in the past 2 years. Okay, if we have not done any sigmoidoscopy, any colonoscopy in the past 10 years, and okay, so I read it again. No flexible sigmoidoscopy or colonoscopy in the past 10 years, and no fit test is done in the past 2 years. Recommendation for patients who had one or more low risk adenomas 5 10 years ago. Okay, so basically, if there's not done in the past 10 years, no fit in the past 2 years, and there's a low risk adenoma, so we can do screening. Yeah. Now the cervical cancer screening guidelines for women age less than 20 recommend not screening for cervical cancer. So this has been changed now. Now the age if is less than 20, not screening is recommended for cervical cancer. Now for women aged 20 to 24, recommend not routine screening for cervical cancer again. Not. We have to remember not screening. Now, for women aged 25 to 29, then we have to recommend pap smear or liquid cytology for cervical cancer every 3 years. So 25 to 29, pap smear or liquid cytology every 3 years. Now, for women age 30 to 69, we have to recommend 30 to 69, 25 to 29, pap smear or liquid cytology every 3 years. For 30 to 69, we have to recommend pap smear or liquid cytology for cervical cancer every 3 years. Same thing. For 25 to 29, pap smear liquid cytology every 3 years. For 30 to 69, pap smear liquid cytology for cervical cancer every 3 years. Then for women age, so roughly is between 25 to 69. Now for women age 70 or more than 70 who have not been adequately screened, recommend screening until 3 negative test results have been obtained. Okay, from age more than or equal to 70, we have to continue screening until 3 negative test results have been obtained. Okay, and for women aged more than or equal to 70 who have been adequately screened, that is 3 successive negative pap tests in the last 10 years, recommend that routine screening may cease. So there are two cases for women with age 70 or more than 70. First, woman whose age is more than, I'm reading here, women whose age is more than 70 or equal to 70 and who have not been adequately screened in the past. Because remember, the screening starts at the age of 25 years. 25 years, yes, and continues until the 69 years. So, if she has been adequately screened in the past, then we have to do further three test results. If they are negative, then okay, no, for who has not been adequately screened in the past, we will continue screening 3 more times and 3 more test results are negative until then. But if the woman has been adequately screened in the past, then routine screening can be discontinued. Okay, so what was the routine screening? Routine screening was every 3 years we are doing pap smear for females. Okay, when she reaches the age of 70, so The three successive test results were negative. So there's no need of any more screening. This is called no need of any more routine screening for that female. Okay. Now we have to see that the note is provincial territorial guidelines vary. Women's age more than or equal to 25 who are or have ever been sexually active recommend screening every 3 years. So we recommend screening every 3 years if cytology is normal. Okay. For women whose age is more than 25 or more equal to 25 or who have been ever sexually active, so we do screening every 3 years. And if the female age is more than or equal to 21, may initiate screening if they are immunocompromised or have having ever been sexually. So, what they say that woman age more than or equal to 25, ever been sexually active, screening every 3 years is recommended. If age is more than or equal to 21, if they are immunocompromised or ever been sexually active. So the age can get a bit low. Normally, it's when age 25. From after age 25, pap smear or liquid cytology is recommended. But if the patient is female is immunocompromised or ever been sexually active or she has been sexually active, then we start screening at 21 years. Okay. Now the next thing we are going to do is this table. Okay. uh, let's make it a bit small and try to understand some basic points from that table. And the last screening was prostate cancer that we're going to read in a while. Okay, first is table. Screening pathway. Anyone with the cervix age more than or equal to 25 or 21, remember what was the criteria for 21? Immunocompromised or sexually active or asymptomatic. What we have to do? Pap smear, cytology test. If the test result is normal, what we are going to do? Return to cytology screening every 3 years. Very right. If the test result pap smear is normal, we have to return to cytology or pap smear every 3 years. Now, ASCUS. What is ASCUS? ASCUS is, here we see all these mnemonics: abnormal squamous cells of unknown significance. So, pap smear result is abnormal squamous cells of unknown significance. Then we repeat cytology in 1 year, not 3 years, 1 year. Okay, after that, if the test result is normal, then repeat cytology in one more year, like after one more year. What is NILM? NILM. ASCUS is abnormal squamous cells of unknown significance, and I think it's just says normal. Okay, normal. Repeat cytology in 12 months. Again, normal. Return to cytology in 3 years. If ASCUS again, then refer to colposcopy. Okay, if ASCUS again, refer to colposcopy. So important thing to remember is if first time ASCUS, we have to repeat in 12 months. If abnormal cells of cytology of unknown significance, again, then we have to refer to colposcopy. Okay, abnormal squamous cells unknown significance, we have to refer to colposcopy if 2 times they are abnormal. Okay. Yes, right. Now the next thing we're going to remember from here in this table is ASCUS, repeat cytology in 12 months, ASCUS again, refer to colposcopy. Okay. Now LSIL, what does LSIL stands for? LSIL basically stands for low grade squamous intraepithelial lesion. Okay. So if the cytology says low grade squamous intraepithelial lesion, we have been doing the same thing. We are going to repeat cytology just like this one. Repeat cytology in 12 months. If normal, again repeat cytology in 12 months. If normal, return to cytology in 3 years. If ASCUS, refer to colposcopy, same. ASCUS, refer to colposcopy. So after reading this, I am going to say, I tell you guys, if the pap smear result is ASCUS or LSIL, Abnormal cells of unknown significance or low grade squamous intraepithelial lesion. Same procedure is followed. Same guidelines are followed. Okay. See one more time. Look, if the result is ASCUS or LSIL, repeat cytology in 12 months. Okay. If now test is normal, repeat cytology in 12 months again. And if again normal, then cytology in 3 years. Now, then if LSIL or ASCUS, repeat cytology in 12 months. If ASCUS again, refer to colposcopy. Alright. If repeat cytology in 12 months, second time if you repeat and ASCUS, then refer to colposcopy. Now the high grade ones. If the pap smear or cytology test results is means high grade, high grade ones, there are some abbreviations: ASC, HSIL, AGC, AIS. Let me tell you what does it mean. AGC, atypical glandular cells. HSIL, look see here. HSIL, high grade squamous intraepithelial lesion. AGC, atypical glandular cells. ASCH, abnormal squamous cells. Cannot rule out HSIL. Okay, AIS, adenocarcinoma in situ. Okay, so all these things, at high grade and glandular cells, and AIS is basically adenocarcinoma in situ. AIS, adenocarcinoma in situ. All these are basically high grade. So what we have to do? We don't have to repeat cytology in 12 months. Nothing, nothing. We just have to refer to colposcopy, okay? Because this is high grade one. Refer to colposcopy now. Understand? So basically, for pap smear, whenever we do, there will be three results: normal, ASCUS or LSIL, low grade ones, and the high grade ones. Okay, high grade one, we just have to refer to colposcopy, nothing else. Okay, now, risk-based screening in primary care after discharge from colposcopy. Discharged from colposcopy with HPV tests were available. Okay, HPV result at discharge negative for HPV return to cytology every 3 years. Okay, what happens after colposcopy? So basically, colposcopy is done for this case. This look here, colposcopy. We were doing colposcopy. Here we were doing colposcopy. So what happens after colposcopy? Okay, after discharge from colposcopy, what is going to do? Discharge from colposcopy with HPV tests were available. HPV result is negative for HPV, human papilloma virus negative. So again, we turn to screening for every 3 years. If the HPV is positive, then annual screening we are going to do. Okay, we for the colposcopy we are going to check for human papilloma virus. If it's negative, we have to return to cytology every 3 years. If it is positive, we have to do annual screening with cytology. Okay, then because it's positive, so therefore we are going to do annual screening with cytology. Now discharge from colposcopy, HPV status is not known. Cytology resulted discharge, return to cytology every 3 years. Cytology resulted discharge, annual screening with cytology. Okay, the last topic of screening is prostate cancer screening. Now, the prostate cancer screening, what we need to remember. The Canadian Task Force recommends that for men age basically 55 to 69, recommend not screening for prostate cancer with PSA test. Simple. If they say that the age is between 55 to 69, we don't screen for prostate cancer with the PSA test. Clinicians should discuss the risks and benefits of screening and potential consequences with each man in the context of his preferences. Okay. Then for men ages less than or equal to 55, recommend not screening for prostate cancer with the PSA test. Again the same thing. Age 55 to 69 not recommended. Less than or equal to 55 not recommended. For men age more than or equal to 70, recommend not screening for prostate cancer with the PSA test. Again, so it's not recommended. Okay, For prostate cancer, PSA test screening for men, even if age is more than or equal to 70, not recommended. Okay, not screening, no screening for all these categories. Now, what will be the basis of recommendation? The potential small benefit from PSA screening is outweighed by the potential significant harms of the screening. Okay, so it is not a very good test because the benefits, they are less as compared to the harms are significantly high, and associated follow-up treatment, for example bleeding, infection, incontinence, and the false positive result in overdiagnosis. Therefore, this pap smear is not a very good screening tool for PSA. No, sorry, this PSA, so not a pap smear. Basically, I'm talking about the PSA test, prostate specific antigen test, that is not considered a very good screening tool for prostate cancer because it is highly false positive, false negative results, and the harm of doing this procedure is more as compared to the benefits, and there can be risk for bleeding, infection, incontinence, and false positive results, and sometimes of course the false negative results as well. For men aged 55 or less than equal to 55, or 70 or more than equal to 70, there is no evidence that screening with PSA test reduces mortality, whereas there is evidence of harm. Therefore, it is not recommended because of this reason, that the benefit is less as compared to harm. For men ages 55 to 69, there is inconsistent evidence of small potential benefit and evidence of harm. But again, is not highly recommended because the evidence of benefit is less and harm is more. Okay. Okay, sometimes, okay, after reading all these guidelines from 2025 edition, we need to refer to the new guidelines as well. And sometimes these screening guidelines do change with the passage of time. So it's even recommended that we need to look at the 2026 guidelines if they are the same or little bit changed. Okay, I'm signing off for now. Hope to see you soon with our next session on the family medicine topic. And in our next video, I'm going to cover the next part of the family medicine unit, that is the health promotion and counseling, and behavioral change, nutrition. All these things are very important. We need to learn about that, and obesity, and I think we will cover up till obesity. Okay, see you soon in our next video. Thank you so much. Have a good day. Take care. Bye.